Neurological diseases that can affect the larynx. They include patients who has Parkinsonism, essential tremor, patients with cerebrovascular accident, and then patients with myasthenia gravis, dystonias, including spasmodic dystonia, and then spasmodic dysphonia, and then cerebellar lesions, multiple sclerosis. So some of the neurological diseases that affects the larynx are systemic diseases, and some of the diseases are local diseases that can be treated in the clinic. So the three local diseases that can be treated in the clinic are essential tremor, spasmodic dysphonia, and unilateral vocal fold paralysis. So the others usually is treated by the neuromedical specialist. So when you are presented with a patient with voice disorder, they can present with other associated symptoms. Some of the signs or symptoms can suggest that the disease is in fact neurogenic in cause. Number one, if the patient has vocal fatigue. Number two, if there's obvious tremor. But if you have never listened to tremorless voice, then you won't know what it is. So the learning point for this lecture is listening to the voice and trying to identify which ones are essential tremor, which ones are spasmodic dysphonia. Of course, unilateral vocal fold paralysis, I've already shown an example of a patient with unilateral vocal fold paralysis. Vocal strain or phonatory breaks, this we call stoppage. Altered resonance present in pseudobulbar or bulbar palsy. Patients with associated dysarthria in cerebrovascular accident. Associated dysphagia also may be present in cerebrovascular accidents or patients with multiple sclerosis or myasthenia gravis. So when trying to pick out which ones are local and which ones are systemic cause, which ones you can treat, which ones you can't, first and foremost, you must ascertain whether the voice disorder are exclusive to phonatory tasks. Okay, so if the patient has problems with the swallowing or breathing, most likely it is not essential tremor or spasmodic dysphonia. So the patients usually, patients with essential tremor or spasmodic dysphonia, they don't have problems with swallowing. They don't have problems with breathing. Once they have, maybe is motor neuron disorder, multisystem atrophy, cerebrovascular accident. Second is the presence of phonatory breaks. Phonatory breaks are basically vocal stoppage. The patient will just explain to you to say that, I want to say something, but some parts or some phrases are then cannot be heard. It's basically just missing. So we'll talk about these phonatory breaks now. You just listen to this video.
4, 5, 6, 7, 8, 9, 10.
Okay, so you can see that this patient is a female patient and it is very difficult for her to speak. She's frowning like crazy. When the voice comes out, it appears, you hear it's very strained. And there are some fragments of the speech missing. Okay.
4, 5, 6, 7, 8, 9, 10. This one. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay, so now you hear this strained voice, there's phonatory breaks, the sound of the voice is very it's very strangulated. So this patient has adductor spasmodic dysphonia, adductor type. So when the patient voice, you hear the strangulation occurring a bit worse, okay? Especially when there is vowels or consonants, voiced sound, it is more apparent. When the patient says E, the speech is very strangulated and the phonatory breaks are non-rhythmical. Okay? So let's differentiate between rhythmical and non-rhythmical phonatory breaks. Rhythmical phonatory breaks occur in essential tremor, whereby non-rhythmical phonatory breaks occur in spasmodic dysphonia. This is an example of rhythmical phonatory breaks when the patient says a long E. Non-rhythmical. Okay, now let's go to rhythmical. Can you hear it? Yeah, again. So this is typical of essential tremor of the voice, whereas this is typical of adductor spasmodic dysphonia. It is non-rhythmical. Okay, so essential tremor of the voice may come with some endoscopic findings. Okay, so when you scope the patient, most of the patients with spasmodic dysphonia, you won't be able to see any abnormalities. So the patient's vocal fold can abduct, the patient's vocal fold can adduct, although sometimes during adduction you may see a bit of a squeeze, but you don't see any abnormal movements. Compared to patients with essential tremor of the voice, you may be able to see some movement. So this patient has some abnormal movement there. Can you see at the supraglottic region, yeah, at the vallecula there, at the pituit of the epiglottis, there's some abnormal movement. So this patient has intrinsic type essential tremor. So the tremors are intrinsic within the larynx only. So this is an example of a patient with extrinsic type tremor. So not only you see some abnormal movement over the larynx, but you also see other movements, some tremors going on at the pharyngeal region. So this is an extrinsic type. So with this type, you may be able to treat this patient with some intralaryngeal botulinum toxin injection. But if you're dealing with this type of tremor, an extrinsic tremor, more than that will be necessary, because you can't treat the tremors that's occurring at the pharynx with just intralesional or intralaryngeal botulinum toxin injection. Okay, let's go through another way to differentiate.
3, 4, 5, 6, 7, 8, 9, 10.
Okay.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Now, this patient has adductor spasmodic dysphonia. When you ask the patient to say E or read a standard passage, voluntary speaking, the patient really struggles. But when the patient whispers to produce sound, you can hear that the speech is much more clearer. There is no phonatory breaks. Because whispering is a vegetative function of the larynx, therefore it is not affected, or the phonatory breaks disappear with this vegetative function. Okay, so we went through a few of the differences between spasmodic dysphonia and essential tremor of the voice. The first one is they are exclusive to phonatory tasks. They are characterized by phonatory breaks. Essential tremors are rhythmical compared to spasmodic dysphonia, which are non-rhythmical. Both spasmodic dysphonia and essential tremor is seen worse with purposeful tasks of phonation, whereby if, let's say, the patient uses the vegetative function, for example, whispering or cough or emotional speech, the phonatory breaks tend to lessen or even disappear. Okay, to differentiate between adductor type and abductor type spasmodic dysphonia, these are some of the things that you may want to ask the patient to do. For example, for adductor type, it's difficult for the patient to say 80 to 89. 80 is difficult. 8 is difficult. For abductor type, 60 to 69 will be difficult. Voiceless consonant more difficult with abductor type. Voiced sound more difficult with adductor type. Typical sentence that you may want to use, and this is something new that I learned. So there is a new paper from Dr. Nupur and her colleagues. If, let's say, you were to take patients with adductor type spasmodic dysphonia, their maximum phonation time will be more than 20 seconds. Abductor type, the maximum phonation time will be less than 10 seconds. Okay, so spasmodic dysphonia is a focal laryngeal primary dystonia that causes tightening of various intralaryngeal muscles. So it can be the interarytenoid, thyroarytenoid, lateral cricoarytenoid, or even posterior cricoarytenoid muscle, then you classify it as abductor spasmodic dysphonia. So it induces movement disorders in the larynx, and it is exclusive to volitional cortically driven system. So if, let's say, the speech is being activated by the limbic system, for example during crying or when the patient is happy, it is not affected. Okay, so the diagnosis, we've talked about this. This is something that your patients may tell you. Alcohol intake improves spasmodic dysphonia. There's even an open label study studying sodium oxybate in patients with spasmodic dysphonia, but it works only in patients who is responsive to alcohol. So if the patient do not show any symptoms of improvement following ingestion of alcohol, the patient will not respond to sodium oxybate as much. So in fact, if they took only patients who are alcohol responsive, only 56% of the patients do improve with sodium oxybate. So much has been said about the etiology of spasmodic dysphonia, but we now know that it is secondary not to the motor system, but it is secondary to the laryngeal sensory feedback. It is the gamma motor fiber that is affected, in which there is a lot of high gamma bias at the muscle spindle due to high gamma motor neuron activity. So another paper, this is a very interesting paper. They took about 5 patients only. They stimulate the gamma motor fiber for about 5 days consecutively, and they were able to find that there is improvement in the patient's symptoms. However, this improvement, it is not long lasting. Okay, another paper which is very interesting in spasmodic dysphonia, they used laryngeal vibration as a non-invasive neuromodulation therapy. 9 out of 13 patients able to show good response. So the most widely used treatment in patients with spasmodic dysphonia is botulinum toxin. Why we utilize it a lot? Because it treats many areas concerned in spasmodic dysphonia. So they will inhibit the acetylcholine, causing a bit of muscle weakness. This gives rise to the side effects. There is changes in the laryngeal sensory feedback, and the ongoing metabolism of the botulinum toxin creates a dynamic state. Therefore, there is less central adaptation. So although the main pathology is centrally, but you still have improvement in the symptoms due to the ongoing metabolism of the botulinum toxin. There will also be decreased activation of the muscle fibers due to inhibition of the gamma motor neurons that we talked about earlier on, and the action of the on the contralateral muscle. In most cases, we only inject botulinum toxin to one side, but yet the patient had good response. And you don't need to inject both sides of the paraglottic space, or both sides of the thyroarytenoid muscle. So the action to the contralateral muscle is due to modulation of the laryngeal muscle that affects the sensory feedback loop. So all this mechanism of how botulinum toxin treats patients with spasmodic dysphonia was documented by Dr. Blitzer in year 1986. So these are the 3 preparations for botulinum toxin that is available. We have botulinum toxin, ONA botulinum toxin A, available in Malaysia, and then this part, abobotulinum toxin. This is available in Malaysia. The daxibotulinum toxin has just been introduced to the US market this year, so it's supposed to give us a more prolonged action. Yeah, similar to botulinum toxin and Dysport, but longer duration of action. So it can cover more months. So probably there'll be good news for our patients, and so we don't need to give the botulinum toxin more frequent. So standard textbook will say that you need to give 1 to 2 units of botulinum toxin to both thyroarytenoid muscle. After the injections to the thyroarytenoid muscle, the patient will have these different phases. The first phase is the breathiness phase. That will take 1 month. And then after that, the patient will have good voice. Then the last phase, there will be recurrence of symptoms again. So once you inject the botulinum toxin, breathy, normal, recurrence. Breathy, normal, recurrence. So that's why you need to repeat the botulinum toxin injection to the target muscles. So now we are going to a more personalized approach in which we alter the dose. We make the dose less so that there will be less breathiness phase. Okay. Number two, we can alter the frequency. So if let's say the patient do not want to suffer from the side effects, the frequency can be made closer to each other. The dose can be made less at each time you inject. So this can reduce the side effect, but the patient will need to have the injection more frequently. Thirdly, if let's say your patient do not respond to the initial injection, you must think about the different muscles, because sometimes you're not targeting the correct muscles. So you can use laryngeal EMG, target the different muscles, and then give botulinum toxin to that specific muscle. Fourth, you can try supraglottic injections to reduce the side effect, to reduce the phase of breathiness, and increase the duration of treatment, so you don't need to inject too frequently. So this is an example of a patient with abductor spasmodic dysphonia. Maximum phonation time is reduced. The patient presents with a breathy type dysphonia, and then you will be able to listen to the breathiness or the air leakage that the patient presents with. Okay, so you can hear the air leak, yeah? That is typical of abductor spasmodic dysphonia, yeah? So first injection, we injected 5 units at the thyroarytenoid muscle. The patient had a better voice, but the breathiness was prominent, lasting for about 3 months. And with 5 units of botulinum toxin at the thyroarytenoid muscle, the patient had good voice up to 6 months. So you can hear her voice after the injection, it was good. So for the second injection, she wanted to try the supraglottic injection. So with the thyroarytenoid dose, we triple the dose and we administer it to the supraglottic region. So second injection, she received 15 units of botulinum toxin at the supraglottic region, and she had better outcomes with this injection. So you can hear to the patient's voice, this is 1 month post-procedure.
4, 5, 6, 7, 8, 9, 10.
Okay, so the voice is really good compared to what it was before.
1.
To the vestibular fold, you choose one vestibular fold and you times 3 the dose at the thyroarytenoid, the initial dose. So the prerequisite for the supraglottic injection is the patient must respond to the thyroarytenoid injection. So if your patient did not respond to the thyroarytenoid injection, you won't know whether the patient will respond to the supraglottic injections or not. Okay? So now, this is a nice study showing how different intralaryngeal muscle may be affected in patients with spasmodic dysphonia. So patients with adductor spasmodic dysphonia, sometimes is the thyroarytenoid muscle, sometimes is the lateral cricoarytenoid muscle. But if you see here, patients with essential tremor, more lateral cricoarytenoid muscle activation or bursts are seen in laryngeal EMG. So that is why sometimes patients with essential tremor, they don't get good response with thyroarytenoid injection. So you may want to target different muscles. As for abductor spasmodic dysphonia, you will find that the PCA muscle or the posterior cricoarytenoid muscle is the one that is affected. Okay, so we learned this supraglottic injection from Dr. James Thomas in one of the APLA conferences in Philippines. So this is what he advocated. You can see it on my YouTube video, no worries. So you get the optimal dose from the thyroarytenoid injection, the one that you inject here. So once you get that dose, you triple that dose and you deliver it to the vestibular fold or the supraglottic region here, and the patient can last up to 6 to 7 months. Okay, right. The main problem with the thyroarytenoid injection is, of course, the breathiness. So if let's say you look at the paper, in which the authors treated patients with adductor spasmodic dysphonia with vestibular fold injection. 76% of the patients do not report any worsening of the voice quality in terms of breathiness. So I'm showing an example of a patient with spasmodic dysphonia. This is her voice at baseline.
Strikes raindrops in the air. They act as a prism and form a rainbow. The rainbow is a division of.
So this patient has adductor spasmodic dysphonia and some elements of essential tremor. So essential tremor and adductor spasmodic dysphonia may coexist in about 26-27% of the patients. Okay, so we decided to give thyroerythenoid injection. That means the injection here, 5 units of botulinum toxin, and this is her voice self-recording taken at 1 week post botulinum toxin injection to the thyroerythenoid.
Like raindrops in the air. They act as a prism and form a rainbow. The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch.
Okay, so you can hear the breathiness, but you can also hear that the phonatory breaks are disappeared. So you've got that breathiness replacing the phonatory break. So essentially, the patient feels better because it's much easier to voice without the phonatory breaks. So then because of the prominent breathiness, so the second injection, I decided to do injection laryngoplasty with hyaluronic acid on both sides of the vocal fold and give the patient supraglottic botulinum toxin injection times 3 the original dose, which is 15 units. So you can see the video here. The double bend needle, now bevel facing up, introduced through the petiole of the epiglottis. We are targeting the paraglottic space now on the right side. So the needle is in. So you can see that we confirm the placement of the needle by just wiggling it a bit. Yeah, there you can see the bulge. And then we give hyaluronic acid 0.5 mL at the right paraglottic space. Okay, you can see that area bugged up a bit. Now we move to the left paraglottic space, perform injection laryngoplasty to reduce the breathiness. So 0.5 mL given there. So now you see both vocal folds medialized. And now needle coming in. This now fresh needle with the botulinum toxin. So now we target the supraglottic region. Okay, and we administer 15 units of botulinum toxin to this patient. Okay. Why I inject the hyaluronic acid at the vocal fold is because of the essential tremor component. So patients with essential tremor, once you give the botulinum toxin, they will have some degree of breathiness. So it is a well-known fact, so that is why we inject with hyaluronic acid first. So this is the patient's voice a week after the 15 units of botulinum toxin at the supraglottic region with the bilateral injection laryngoplasty.
The rainbow is a division of white light into many beautiful colors. These take the shape of a long round arch and form a rainbow.
Just
the
1 week, so maybe botulinum
division
toxin not
of
yet
white light into many beautiful colors.
So
These take the shape of a long round arch.
okay. So I've not heard from the patient for 1 year already. So I'm crossing my fingers. So she has my number on her phone. So usually when she needs the injection, she will call me. So she hasn't called me for the past 1 year. Okay. So there are surgical alternatives for patients with adductor spasmodic dysphonia. So earlier on, Dr. Yakubu talked about type 2 thyroplasty. So I will not talk about this. We also have another surgical procedure, which is thyroerythenoid myoneurectomy. In this procedure, we create an incision parallel to the vocal folds here at the level of the muscle. Yeah. Then after that, we dig into the paraglottic space and try to locate the terminal branches of the recurrent laryngeal nerve. You hook it up and then you laser ablate it. You must find at least 3 to 5 terminal branches of the recurrent laryngeal nerve and ablate it, and you must do it bilaterally. It's painstaking, and it is not very successful. The recurrence rate is high. So that is why we initially we tried to do this procedure, then we abandoned it because it didn't improve the patient's symptoms. We converted back to botulinum toxin, and now with the personalized approach with botulinum toxin therapy for patients with spasmodic dysphonia, I don't think the patients are complaining. So another way to treat is doing selective denervation and re-innervation procedure. This was talked about by Burke and colleague, and even with this technique, you have about 26% recurrence. So with that, I think I'm still going to stick to botulinum toxin injection. So in conclusion, not all neurological condition affecting the voice is treated by us, and we can always perform office injection procedures for neurological diseases affecting the voice. And in Malaysia, at least, I think that patients with spasmodic dysphonia and essential tremor prefer a more personalized serial botulinum toxin injection compared to surgery. I mean, the Indian lady which we tried thyroid myoneurectomy, until now say that if operation, she doesn't want. So she just want botulinum toxin injection. So thank you for your attention.